día de hoy. Muchas gracias a todos y comenzamos ya con la conferencia inaugural que va a ser presentada por el doctor Alessandro Cassini. El doctor Alessandro Cassini es un profesional del Infection Prevention and Control Technical and Clinical Hub del Department of Integrated Health Service Division on Life Course de la Organización Mundial de la Salud. El doctor Cassini va a presentar en inglés y, como saben, no va a haber traducción simultánea, la ponencia titulada Risk Factors for Coronavirus Diseases 2019 in Health Workers regarding the available evidence on risk factors on health workers being infected, as well as the protocol for a case control study. Dr. Cassini, thank you very much for joining us in this very important day for WHO and also for all the countries. I know you are very busy today, so thanks again. I also would like to thank WHO for the support, for the continued support to our national patient safety strategy. So I only want to say to all the people here, indicar que tras la presentación del doctor Cassini podrán formular preguntas a través del chat. Debido al alto número de participantes y de las preguntas que se esperan, recogeremos solamente algunas de ellas y el resto las recogeremos para enviársela a los ponentes y posteriormente a ustedes con una categorización de respuestas. Please, Dr. Cassini, go ahead with your presentation and thanks again.
So do you hear me?
Yes, perfectly.
Yolanda and estimados colegas, es un honor para mí. But unfortunately, I will have to continue in English because my Spanish is not that good. It's more in Español than Spanish. So it's a real honor to be here and present to you the work that we've been doing, let's say, recently together with stakeholders and partners, more specifically on the safety of health workers, and also the estimation of the impact of COVID-19 in health workers in terms of risk factors. So today I will present a little bit about the available evidence and what we know in terms of the burden of COVID-19 on health workers, and also then what WHO has been doing to help and support countries to protect their health workers, and then also a protocol that WHO has developed, a case control study on risk factors for health workers. So I will see if it works. Yes. Okay, so the impact of infections in health workers, I mean, there's the potential impact is obviously further transmission within the healthcare facility or even to the community through their families. And it goes both ways, and I'll show a little bit more about that one. But the impact is not only on the health workers themselves, but it's an impact on the health system. As you have experienced in the past months, there is at a certain point a shortage of health workers because they are either infected and need to isolate, or because they've been exposed contacts and need to quarantine. And this also has an impact on the other health workers that are still working in terms of longer work hours for the remaining staff. And then the impact is also societal. There might be some mistrust from the community and underutilization of essential health services, and that is something that we've been working on quite a lot. There's certainly is an impact in terms of primary care with people that actually prefer not to go to their doctor or to the hospital, and also in tertiary care when so they don't want to go to their general practitioner, but also in tertiary care when they don't want to go to the hospital because they are afraid of getting COVID, or because the services are closed because of outbreaks of the infection in the hospital. So this is just a very quick infographic on the transmission patterns. We have COVID patients and health workers working with COVID patients. They are obviously exposed, but that arrow is not a continuous arrow, because if proper infection prevention and control measures and if proper personal protective equipment is adhered to and is available, because there is some issues in availability, then health workers generally should be safe and should not transmit the disease to the community or to other non-COVID patients. However, we've seen that a lot of health workers that have been infected, and this varies a lot depending on the context, but a lot of them seem to have been infected in the community more than in their occupational, let's say, duties. But this, as I say, does vary a lot and depends on many different factors that now we will look at. One notable source of evidence and information is a living rapid review. So what this means is that it's a systematic review of the literature. And this is, let's say, funded by WHO, and it's done together in collaboration with us at WHO. But a living rapid review means that it's a systematic review of the literature with some caveats, meaning that it enables it to be more rapid. And it's ongoing, it's continuous, so it's updated continuously. And this rapid review from Dr. Chu and colleagues tries to answer three main questions. What is the burden of these infections on health workers, not only of SARS-CoV-2, but of SARS-1 and MERS-CoV? And also, how does that vary according to age, sex, and comorbidities? Second question, what are the risk factors for health workers that are infected? And also, what are the risk factors for household transmission in both directions, meaning health workers infecting household members and the other way around, household members infecting health workers? So some very initial, let's say, pills of results, we found that the proportion of health workers that are infected does vary a lot according to different settings. Now, I just here put some examples. It's not exhaustive. And there are some other, let's say, studies that have found 10 to 15% of all COVID cases are among health workers. There's also up to 34% in one study. As I said earlier, it does depend on many different factors and contextual situations. One sure thing is that the incidence is generally higher in health workers than in the general populations, even more than 3 times higher. And we've also seen that the incidence in health workers follows the epidemiological curve of the general population as well. However, probably also given to the fact that the average age in health workers is generally lower, at least in the first 6 months of the pandemic, was generally lower than the average population. The illness is less severe, mortality is much less than what was found in the general population. Some risk factors is female sex, and that most surely reflects the fact that most health workers are females, having a direct contact with the cases, obviously, and being a nurse. So basically, and on top of that, there are other risk factors which are related to mental health. There's more depression, there's more anxiety, there's more psychological distress, and for sure, there's much more issues in terms of sleep. So being a nurse working in a COVID-19 ward does carry the biggest risk factor and hence the biggest burden of COVID-19 in health workers, at least according to this rapid review. In conclusion from this rapid review, there are several risk factors that have been identified. So as I said, working in high-risk departments like ICUs, not being able to do proper hand hygiene, so maybe not having hand washing stations, or not having alcohol hand rub at the point of care, or even not knowing about hand hygiene technique and the 5 moments of hand hygiene, which are actually even behind me. The improper use of personal protective equipment, working long hours, insufficient education and training, and certain exposure. So certain, let's say, things that are done on the patients, like intubations, etc. And also having a family member increases a lot the chance of a health worker having COVID-19. So these are the risk factors that were found. It's not rocket science. It's all things I think that we were expecting, and but it's important to have it out there and to have the evidence. I also wanted to provide a little bit of the conclusions that we took from, and also that is in the rapid review, is that health workers account for a significant proportion of infections. This is undisputable. Illness severity, however, is generally lower than in the general population, and probably that's related to a younger average age. There is for sure a depression, anxiety, and psychological distress that are common in health workers, especially during the first 6 months of the response to COVID-19. The strongest evidence as a risk factor is that personal protective equipment does reduce the risk of getting the infection. The association in terms of PPE was most consistent with masks, gloves, gowns, eye protection, and hand washing. However, I just also want to underline some, let's say, limitations of all this. For example, in the University Hospital of Hong Kong, even in the COVID-19 wards, they do not use gloves. And this is because they want to remind each other and themselves that they need to perform hand hygiene properly and in the right moments. Certain exposures are associated with an increased infection risk. And training is also very important to reduce the risk of health workers contracting COVID-19. So some other data sources, there is quite a few, so I had to select. The International Council of Nurses today or yesterday came out with a press release that updates the press release that they issued in May 2020, when they were saying that there were more than 90,000 health workers infected around the world, with 260 deaths in the nurses, among nurses. And that the proportion was about 6%. The proportion of health workers infected was about 6%. So now they updated this yesterday or this morning, and with numbers that are obviously have increased because the pandemic has continued. There are more than 1,000 nurses which died in at least 44 countries. So that is a subset of the total number of nurses that might have died. 10% of the total infections are among health workers. That would translate into 3 million health workers around the world that have been infected. Less than half of the countries classify COVID-19 as an occupational disease. And this is extremely important because it does reduce the access to compensation and to proper equipment, training, testing, mental health support, financial support. So they call upon the decision makers to increase evidence and information on data of infection rates among health workers. They do also say that there is an inadequate personal protective equipment available to health workers, and not enough, especially in nursing care homes. There's inadequate testing, so not enough testing, although in general, to be fair, health workers have priority access to testing in most countries around the world. However, for sure, there's not enough access to training in proper infection prevention and control. There's been quite a lot of instances of violence and discrimination against nurses and other health workers, and there surely is a lack of mental health support, especially for those that are working closely with COVID patients. I also wanted to tweak out some more evidence from other papers. These are 4, let's say, papers that I just selected for several reasons. The American MMWR, which is the paper of the US CDC, found that the health worker status represents a subset of the reported cases. So that means that there's not enough surveillance done in terms of defining if the COVID-19 cases are health workers or not. Just to make an example, here at WHO, we receive, we collect the data from all over the world on the number of cases in COVID-19, and we also ask if the case is a health worker or not. But the completion of this data is extremely low. It's I think less than 10%. That means that we can only find out what is the proportion of health workers among all cases through a very small subset. The potential for exposure in multiple settings, especially, so there's a potential for exposure in multiple settings, especially as community transmission increases. What this means is that more community transmission generally translates into an increase in health workers being infected. That indicates that there are quite a few health workers that are infected in the community rather than in the hospital. Another report in Alberta in Canada found that health worker risk was 9 to 11 times higher than in the general population, regardless of where the country or the region risk status. A paper in the British Journal of General Practice in the UK found that certain groups of health and essential workers have been disproportionately affected. So within health workers, the minority ones, what they call in the UK BAME health workers, Black, Asian, or minority ethnic ones, have been much more exposed and have been infected much more than other health workers. Although the frontline health workers may have had a greater exposure than in the general population, the relatively lower mortality rates are probably due to a greater access to personal protective equipment, lower rates of comorbidity. There are fewer older people than in the general populations, and there is also obviously an increased access to testing. Finally, a paper in the British Medical Journal found that risk factors and this was focusing on psychological distress or other health, mental health issues, that staff in contact with affected patients have higher acute or post-traumatic distress and psychological distress. The risk factors for these are being younger, being a junior doctor or junior health worker, having dependent children, or exposure and infections associated with the longer quarantine, having an infected family members that we've already seen, and the lack of practical support, stigma. So stigma also has been found to play an important role. A very recently published paper that I just wanted to cite because it's been, I think, has been done extremely well. Although they do not look at the infections in health workers, they look at nosocomial transmission of COVID-19 in the hospital. Based on more than 9,000 patients in this large US academic medical center over quite a long period of time, have found that they had treated 697 patients with COVID-19. However, they have found around 15 possible nosocomial transmissions. They did an epidemiological investigation on all these 15 and actually narrowed it down to 2 hospital-acquired cases of COVID-19. One was probably infected by the spouse who was coming to visit the patient, and the other one had no known exposures. This really suggests that nosocomial transmission is not inevitable. So we can avoid hospital transmission of COVID-19, especially when rigorous infection prevention and control measures are in place. And I find that their figure in the paper is very telling. I like the fact that they have listed their interventions, their hospital-wide interventions across the time. For example, universal masking or daily patient symptom screening, etc. And you can see how the small light green bar remains pretty low across all this time. So finally, a Cochrane review of the literature, I think, has found some very interesting results as well, based on the evidence that has been published until now. The barriers that they found for health workers' adherence to IPC guidelines and other respiratory, not only for COVID-19, but in general for respiratory infectious diseases, were that guidelines might be too long and ambiguous. And this is a common issue in guidelines. They might be of limited quality. Other barriers is in very high workload and fatigue, having a low level of support from management, having a low level of IPC training, having insufficient space to isolate the patients or lack of personal protective equipment or poor quality equipment. Isolated patients felt frightened and stigmatized, etc. And this also is a barrier. The components that were identified that facilitate the adherence of health workers to IPC is to minimize overcrowding, fast-tracking infected patients, restricting the visitors, and providing easy access to hand hygiene. So as you can see, for example, in this sentence, the only IPC component is hand hygiene. There's a lot of other non-IPC interventions that are extremely important to enable adherence to IPC and to enable and to be able to reduce the risk of infections in health workers. Obviously, clear guidelines that are clearly communicated are extremely important. Having some fear of infecting themselves and other families actually is important for health workers to be able to think about IPC continuously, and also the guidelines need to target not only health workers that are directly working with patients, but they should be enlarged to the whole admin staff or kitchen staff, to the whole staff of the hospital or the healthcare facility. So WHO has been doing quite a lot recently in these past 8 months. Especially on, well, I work in the infection prevention control hub, so obviously I'm going to focus on those guidances, but there are many other looking at different aspects like clinical management, etc. So I just wanted to list a few here that are available, most of them in English, although some of them are translated also into the other UN languages, which include Spanish. We also have a lot of trainings that are all, let's say, collected in a space called Open WHO. So here, for example, I'm just making some examples on the standard precautions, how to put on PPE, how to put off PPE, and other IPC measures that are targeted to COVID-19. These are also other examples of courses And we haven't stopped there. There are more coming. These are definitely translated in many languages, beyond the 6 languages of the UN. And they have over 1 million enrollments, at least until a few weeks ago. So they've been pretty successful. These are other examples of courses that WHO offers. So the waste management, the environmental cleaning, standard precautions for injections, and also more generally on the IPC core components, which is the basis of WHO work for IPC, and microbiology, obviously. And there's much more. We have more material also for the general public on how to wear fabric masks and how to wear medical masks. There's a video also on how to create or how to produce a fabric mask. And these are all videos accessible to everyone, and they are targeted to the general public. I just also wanted to flag, as I was mentioning earlier, that all the work in IPC at WHO is based on the guidelines for core components of IPC at the national level and the healthcare facility level. These were published in 2016. Then last year, we also published the minimum requirements, which are really the basics of IPC that need to be in a hospital in order to be able to say that the hospital is safe for the patients and the health workers. And today, I'm happy to say that we've just published the core competencies for IPC. So what these are the what an IPC professional as a minimum should know in order to call herself or himself an IPC expert. I think this is very important in all countries, not only in low-income countries, which are those that we obviously target the most, but also in high-income countries where having an IPC nurse or focal point in all hospitals is extremely important. We also are working with donors, and this is obviously targeting more lower income countries, where we collect donations in order to provide a supply chain for personal protective equipment and other things to countries that need them. And this is done in partnership with a large number of other organizations like the Global Fund, Gavi, UNITAID, and particularly UNICEF. So this is just a long list of other important resources that you can find, and I'm sure that these slides will be shared with you so you can look at them later. The long list, I'm sure you will find some of these useful in your own context. Just to very quickly let you know that so as I've been showing, there's quite a lot of guidances. Notable ones are considerations for the public health and social measures in the workplace in the context of COVID-19, laboratory testing criteria for releasing COVID-19 patients from isolation. This is extremely important, especially because there are quite a few patients that continue on being positive even for months to PCR testing. There's IPC guidance documents, including IPC during healthcare, rational use of PPE, etc. But just to let you know that we continue on working on guidances, not only updating those that are available, but there are some pending ones on workforce policy and management and occupational health rights and responsibilities. Now, very briefly, I'll try to do this in a few minutes so that we have time for a few questions. I was deployed in Italy at the beginning of the epidemic, when it was still an epidemic at the time. And it was pretty obvious since the start that there were a lot of health workers that were being infected. So together with colleagues there, apart from other response duties that I was doing, I focused on a research protocol on risk factors for health workers that are being infected. And this is part of a large group of protocols called the Unity studies. And these Unity studies have other protocols, but this is the only one that has a international multi-center research effort that is ongoing. So if you're interested to participate, I will show you some email addresses later, but please get in touch. The objectives are to assess the risk factors and the effectiveness of IPC measures, but we do also follow the patients for at least a month and to determine their serological response. And we do provide also some funding for those who want to participate in the international multi-center study. It's a nested case control study. So basically what this means is that once you find a health worker who is positive, they become a case, and you enroll 2 to 4 controls per case. And then you do some questionnaires, you ask them some questions, you take blood to do the serology, and then there's also a form for the healthcare facility, because as we've seen, it's not only about IPC and personal protective equipment. There are a lot of other structural enablers in the hospital that are important for the response. We define exposure just to make sure that everybody is on the same page. There's obviously inclusion criteria and exclusion criteria for both cases and for controls. And these are the different questionnaires that are available. We also produce for those questionnaires a sample size calculation that it varies a lot according to risk factors that are considered, and also on the outputs and hypotheses. We provide a data collection platform with a template that is easily, let's say, implemented on your own computers. And with this, you can share the data with the WHO. Obviously, the data remains of the ownership of the principal investigators at the local level, and then they decide how and when to share the data with WHO and what to do with it. These are some possible outputs. It's mainly odds ratios around the IPC risk factors. And as I was saying, we are coordinating an international multi-center study. We have quite a lot of sites across the world that are already participating right now. To ensure quality and completeness of the data, we let's say, came up with a list of criteria that needs to be included. And these are the next steps to take. In case you are interested, just review the protocol and decide if you want to participate in the international multi-center study. And then there are a few, let's say, formal steps like confidentiality, because we want to make sure that you're not, that no one is using this data against the health workers, and also data sharing agreements. Just wanted to acknowledge some of my colleagues with whom I've been working on health worker, on these slides, and on health worker infections during these last months. And please feel free to email me for any questions, or if you also, particularly if you want to participate in the multi-center study. So thank you very much. And maybe we have a few minutes for some questions if there are any. Thank you, Yolanda.
Thank you, Dr. Cassini. Thank you, Alessandro, for your excellent presentation. And also, thank you for collaborating with us. We have some hospitals that are going to participate in the study that you just present. We have a couple of questions. We are very tight on time, but I would like to ask you that you present very clearly, and we already know that the health professionals suffer and are suffering in this pandemic. And this is a situation similar that could happen in other high-risk industries. We can say that the difference with the healthcare industry is that these other industries have a very standardized approaches to protect their professionals, and also a much stronger culture of patient, of security. Sorry. Regarding that, and we know that we have been adopted at some of the methods and tools from these high-risk industries, But in order to avoid a similar situation that we had previously affecting the professionals, what priority solutions should we learn from these other industries and we should undertake? That is one of the first questions. And the second one is regarding the risk of the professionals according to the different level or category of professionals. Do you think it should be a solution, a useful solution to prepare specific approaches for different groups of professionals to deal with the risk of this pandemic? And if you could provide an example, if you have it. Thank you very much. And if we have time, we will ask you another third question.
So, yes, indeed. There's been often made this, let's say, parallelism between, for example, the aeronautic industry and patient safety. And I think we've learned a lot through standard operating procedures, through checklists, and they are extremely important and we've not only learned a lot, but they've had a significant impact in terms of not only in the infection prevention control, but for example, the checklists and surgery, etc., have really helped us make sure that we do increase patient safety to the levels that it should be. However, I want to stress the fact that proper infection prevention and control is needs to happen through a culture change. And if you, and I'm sure you know Yolanda very well, and I'm sure many of the colleagues that are listening know the core components of IPC that were published by WHO. But there is one core component in particular, which is called the multimodal approach. And I think I had a slide where we see a little bit how, let's say, the whole core components work. But the multimodal approach is...
I'm sorry, I think we don't have time for another slide, but...
No, don't worry, it's fine.
Okay.
No, but what it means is that basically you are working together with the health workers in defining what are the priorities and the issues that are relevant to increase the safety of health workers and of patients, and to do proper IPC in a multidisciplinary team. So it's a bottom-up approach through multidisciplinary, where you have microbiologists, you have infectious disease experts, etc., and they work together with the frontline staff to work out what are the priorities and tackle some very specific issues. And you start with those, and then you scale it up to other, let's say, maybe specific interventions that are relevant and important in the context that we're looking at. Obviously, however, the other components are extremely important, and they go all together. Guidelines, having training, having specific indicators to monitor, and surveillance of healthcare-associated infections, etc. These are all extremely important, and they go together. But it's the general approach, which we call the multimodal approach, which is something that we think will be the best way to make it sustainable in the long term and ensure some culture change, because culture change is really what we're looking for. These specific approaches to professionals, obviously, these are absolutely needed, but this does not take anything out of the fact that they need to be developed in a multidisciplinary team across the board. So if you're looking at guidelines for cleaners, let's say, these should not only be done by a manager or an admin staff and then imposed on the cleaners. They should be done together, obviously, not only with the cleaners, but also with the, let's say, clinical staff and nursing staff that are involved in the general IPC implementation in the hospital.
Okay, so thank you very much, Alessandro, Dr. Cassini. It was excellent. We will be in touch, and thanks again to you and your organization for support this day today and for your excellent presentation. See you soon.
Thank you very much. It's been a real honor.
See you soon.
See you soon. Bye-bye.
Bye-bye. So, ahora vamos a tener unos minutitos de vídeo mientras está preparando la mesa 1.